Good morning. I'd like to bring to order this meeting of the House Subcommittee on Military Construction and Veterans Affairs. Mr. Secretary and guests, we welcome you and your team here today to discuss the fiscal year 2017 budget request. And I certainly appreciate, Secretary, your visit to the office last week. As we discussed, your budget request and those of all non-defense agencies face a high hurdle this year. The general increases proposed generally are built on a very not a very solid foundation, in my view. Redefining discretionary programs as mandatory and tax hikes for the middle class, that will not be entertained by this Congress. We have to work within the budget agreement we have, which, as I discussed with you, permits only a $40 million increase across all non-defense subcommittees from the fiscal year 2016 level. Your budget requests a $3.6 billion increase, which is going to be a real heavy lift in this current environment. In addition, you're in an enviable position of having to pick up the costs of the choice program as the mandatory spending created by the authorizers runs dry beginning in 2017 and in full force in 2018. But we're certainly very interested in hearing your ideas about top funding priorities for the VA and for what you've been doing to improve management of the department. The roster of officials accompanying you today is a clear sign of some of the management changes you've made. I don't think a single one attended our budget hearing last year, if I'm not mistaken. But before I ask you to introduce your team and provide a summary of your written statement, I'll ask the ranking member if he'd like to make any opening remarks. And before I do recognize him, I do want to say I know that we're in a difficult budget environment. I also know, too, that the day is coming where we're going to have to figure out a way to better integrate the veterans into civilian health systems, ensuring that veterans can be cared for in the communities where they live. It is going to be increasingly difficult over the long term to continue to build capacity within the VA system and to provide more choice sustainably and simultaneously. It'll be very difficult. So I look forward to hearing your opening statement, Mr. Secretary. Before you, I'd like to recognize my friend and colleague from Georgia, the ranking member, Mr. Bishop.
Thank you very much, Mr. Chairman, and welcome, Mr. Secretary, and welcome to all of your team. You're very ably supported this morning, and we appreciate that very much. Mr. Chairman, I don't think anyone will ever be able to say that President Obama or this Congress, whether under Democratic control or Republican control, has not provided the proper resources to the Department of Veterans Administration. Like in previous budget proposals, the VA's budget continues to grow. In fact, since 2009, total VA funding has grown by 86%. Let me just say that again. Since 2009, it has grown 86%. How many other agencies can say that? FY17, of course, is no different. The VA sees a healthy increase of 5% over the FY16 enacted level in the request. And when you include mandatory funding, the President's FY17 VA budget proposal provides $182 billion, a 9% increase over the VA's FY16 funding, which is almost double the VA's 2009 budget. Mr. Chairman, as we've discussed in detail, I'm concerned about the future of the VA. I believe that we need to provide the best care possible. However, I also believe that we need to control costs so they don't spiral out of control. Furthermore, we need to make sure that the resources that the committee provides are used effectively and efficiently. Furthermore, I'm concerned about the current proposal for reform of the appeals process. As we know, the current process is complicated, ineffective, and veterans are waiting on average about 5 years for final decision, and that wait is certainly unacceptable. And I applaud you for trying to solve the problem, but I believe that this proposal needs a serious review. To me, it's unclear whether or not the authorizers are going to take up the proposal at all. Another topic that I hope we can discuss today is the Veterans Experience Office of the VEO. My understanding is that the VEO was established as part of the MyVA task force under the Office of Enterprise Integration in 2016. This office was funded through the OEI reimbursements, and now the FY17 budget proposes to make the VEO a standalone office within the General Administration. Mr. Secretary, I believe that you're honestly trying to make change at VA, and change needs to happen at VA, but as I look at the changes like the VEO and the MyVA, my concern is that we're setting up programs at the VA that the next secretary may change, and valuable resources may ultimately be wasted. I want to make sure that the investments that the committee makes will stick. As you can see, we have a lot to discuss today, and I thank you for the opportunity to share my concerns, and with that, I will yield back, and of course, after your testimony, we will have some questions for you.
I'd like to thank you, Ranking Member. Before I recognize Secretary McDonald, I'd like to recognize the full chairman of our committee, gentleman from Kentucky, Mr. Rogers.
Thank you, Mr. Chairman. Mr. Secretary, guests, welcome. We appreciate your taking the time to be here and respond to our inquiries about your budget submission. VA is entrusted with one of the most central responsibilities of government, providing comprehensive care for our veterans and ensuring that they enjoy the highest quality of life after they have served. With a high number of young veterans returning from Iraq and Afghanistan and the number of disabled veterans rising, the challenges facing your department are mounting on several fronts. Our veterans deserve and have been guaranteed access to quality health care, timely decisions on their disability filings, as well as assistance with education and employment. And they look to your department to fulfill each of those promises. Not so long ago, we learned of negligence and mismanagement at the VA that left veterans on wait lists for critical health care services for months at a time. Last summer, 1 year after these facts surfaced, we received reports that the wait lists had increased by 50% in just 1 year's time, even after the Congress appropriated $15 billion to reduce the wait lists and hire more caregivers. To this day, the magnitude of the wait list problem remains unclear, and the VA Inspector General is just now beginning to release the findings of their investigation into the 73 hospitals across the country that forced our veterans to wait for care that in many cases never came. You and I both know that treating our veterans with this level of disregard is utterly unacceptable and truly deplorable. Everyone on this panel wants to hear more about what you're doing to bring these wait times down and offer our vets the care that they have earned and deserve. Congress has responded to the challenge by offering veterans the option of accessing care outside of the VA system through the VA Choice Program, and we need to continue to have a national conversation about the optimal way to match each veteran with the health care provider that will best serve them. At the same time, we must continue to move forward with initiatives aimed at modernizing and streamlining VA programs and services. Digitizing VA medical records has been an important focus of you and the Congress now for several years, and we've been pressing the department to get this done for some time now. Ms. Secretary, you've requested a funding increase for the digitization of VA medical records in your fiscal year 2017 request. The committee appreciates the department's prioritizing of this project this year, and we support your efforts to make the claims process more efficient and reduce the backlog of veterans' claims. Our veterans seeking access to their rightfully earned benefits are depending on you and us. Finally, I know you're well aware of the epidemic of prescription drug abuse facing our civilian population and our veterans. This time last year, we discussed the troubling news that at least one VA hospital had been overprescribing opioids and contributing to this epidemic that we've been fighting so hard to prevent. We now know that at least one veteran lost his life because the proper prescribing protocols weren't followed and the staff on hand was not equipped to intervene. I'm pleased to see that the VA Inspector General investigated this unfortunate case and that the facility is now investing in training programs for its employees to prevent such a tragedy from reoccurring. This committee is interested to know how the department is acting to ensure that this sort of mismanagement and recklessness is not occurring at other hospital facilities and that it never happens again under our watch. You have a committed partner in this committee in the fight against opioid abuse and addiction among our veterans, and we stand ready to provide you with the support you need in this effort. CDC has said that prescription drug abuse is a national epidemic, that we're losing more people dying of overdoses than car wrecks. And veterans, of course, are not exempt from that phenomenon. But we do have the facilities, I think, to go a long way toward erasing the problem for veterans. Thank you for being here. Look forward to your answers.
Thank you, Mr. Chairman. And before we again recognize Secretary McDonald, I'd like to recognize our distinguished friend and ranking member, the gentlelady from New York, Ms. Lowy, for her remarks.
And I want to thank Chairman Dent and Ranking Member Bishop for holding this very important hearing, and I join my colleagues in welcoming Secretary McDonald and all of our distinguished guests this morning. This subcommittee must help address the serious challenges facing the Department of Veteran Affairs in delivering to the men and women who have faithfully served our nation the recognition and benefits they deserve. Mr. Secretary, I thank you for your commitment to bettering the lives of veterans, in particular your dedication to increasing accountability within your workforce and initiating programs designed to meet the needs of the most vulnerable and at-risk veterans has been an inspiration. I thank you for your commitment and your efforts to reduce the claims backlog, an issue of great concern to the chairman, to both chairmen, and for everyone on this committee, and I would say the entire Congress. And although I'm pleased the backlog is down considerably from 2 years ago, I know we all know there's a lot more work that we have to do. Yet, as the drawdown of forces in the military continues, I hope the VA will prioritize backlog reductions with the increase of men and women seeking VA care and benefits. In addition, I'm concerned about the health care female veterans receive. Female veterans are one of the fastest growing groups receiving medical care through the VA, yet they still face cultural roadblocks in a system that has traditionally focused on the care of men. I believe that we need to start a discussion about updating the VA system to better reflect the gender makeup of our armed forces and future veterans. Mr. Secretary, I again thank you for being here today, for your service to our country. I look forward to hearing your testimony.
Thank you, Mrs. Lowy. At this time, I'd like to recognize Secretary McDonald. Please proceed.
Thank you. Chairman Rogers, Chairman Dent, Ranking Member Lowy, Ranking Member Bishop, and members of the subcommittee. Thanks for the opportunity to present the President's 2017 budget and 2018 advanced appropriations request for the Department of Veterans Affairs. I've submitted a written statement for the record. The President's 2017 budget proposal is another tangible sign of his devotion to veterans and their families. It proposes $182.3 billion for the Department in fiscal year 2017, which includes $78.7 billion in discretionary funding a 4.9% increase above the 2016 enacted level, largely for health care. It includes $65 billion for medical care, a 6.3% increase of $3.9 billion over the 2016's enacted level. It includes $12.2 billion for care in the community and a new medical community care budget account to increase transparency on VA's spending for non-VA care as required in the VA Budget and Choice Improvement Act. It provides $66.4 billion in advance appropriations for the VA medical care programs in 2018, a 2.1% increase above the 2017 request. It provides $7.8 billion for mental health. It funds veteran contact centers, and it funds the Veterans Crisis Line modernization. This proposal provides $1.5 billion for effective hepatitis C treatments for at least 35,000 veterans, $1.2 billion for telehealth access, $725 million for veterans caregivers, and $515 million for health programs for women veterans. The proposal includes $103.6 billion in mandatory funding for veterans benefit programs in 2017 and $103.9 billion in advanced appropriations for our three major mandatory veterans benefits accounts. It requests $2.8 billion for the Veterans Benefits Administration, including support for an additional 300 staff to reduce the non-rating claims inventory and provide veterans with timely decisions on non-rating claims. And it includes $156.1 million for the Board of Veterans Appeals. That's an increase of 42% over the 2016 level as a down payment on a long-term sustainable plan to eliminate the appeals backlog. The budget supports VA's 4 agency priority goals. It supports our 5 MyVA transformational objectives to first, improve the veteran experience, second, improve the employee experience, third, improve internal support services, fourth, establish a culture of continuous improvement, and fifth, expand strategic partnerships. It provides $2.6 million for the MyVA Program Office to help integrate MyVA initiatives across the enterprise, and $72 million for the Veterans Experience Office so we can continue establishing high customer service standards. And it supports our 12 breakthrough priorities for 2016 and into fiscal year 2017. These are critical investments if we're serious about transforming VA into a high-performing organization veterans deserve and taxpayers expect. Over 3 decades in the private sector, I learned firsthand what makes a high-performance organization, and that goal is within our reach. We already have a clear purpose and strong values and sound strategies. We have a growing team of talented business and healthcare professionals making innovative changes. And you're right, I'm the only one at this table who testified last year at the hearing. 10 of our top 16 executives are new since I became secretary. And we're building responsive systems and processes shaped by design to meet veterans' needs. For veterans, that means veterans have 24/7 access to VA systems and know where to get the answers. Veterans calling or visiting primary care facilities at a medical center have clinical needs addressed the very same day. Veterans engaged in mental health care needing urgent attention speak to a provider the same day. And veterans calling for new mental health appointments receive suicide risk assessments and immediate care if needed. For employees serving veterans, it means training on advanced business techniques that drive responsive and innovative change, performance management systems that resonate with employees and encourage continuous improvement and excellence, clear performance expectations, continuous feedback, and employees equipped with the tools to achieve excellence. It means that executive performance ratings and bonuses reflect actual performance and take into account relevant inputs like veteran outcomes, employee surveys, and 360-degree feedback. And it means modern automated systems in place of antiquated and costly paper processes. We're advancing along all these lines and many others. Growing a high-performing culture at VA is what our Leaders Developing Leaders process is about. We launched Leaders Developing Leaders, or LDL as we call it, last November with 450 senior field leaders. We've trained more than 5,000 leaders so far, and we met again Monday and Tuesday at our Leesburg, Virginia National Training Facility to build on the growing momentum and share best practices that we'll leverage across VA. You see, LDL is a continuous enterprise-wide process to instill lasting change. By year's end, we'll have trained over 12,000 senior leaders, empowering more and more teams to dramatically improve veterans' care and service delivery. Private sector leadership experts are teaching VA teams cutting-edge business skills like Lean Six Sigma and human-centered design. Human-centered design and Lean are helping leaders reshape the compensation and pension process that veterans find burdensome. We're planning to automate performance management to streamline the process and improve rating accuracy. And we're finding new ways to provide higher quality care and benefits more efficiently. Our pharmacy benefits management program avoided $4.2 billion in unnecessary drug expenditures last year. We've saved over $500 million in travel spending since 2013, exceeding goals of the President's campaign to cut waste. We've reduced employee award spending $150 million and SES bonuses 64% between 2011 and 2015 by rigorously linking awards to performance. Since 2011, we've saved $16.6 million using more efficient training and meeting methods. We're already saving $10 million a year under our MyVA 5-district structure, which we announced in January of 2015. We saved approximately $5.5 million from 2011 to 2015 by strengthening controls over permanent change of station moves. And we'll save millions each year in paper storage now that we've implemented the electronic claims processing. So we are committed to doing everything we can for veterans with everything we're given. But more than 100 legislative proposals for meaningful change require congressional action. Over 40 are new this year, some absolutely critical to maintain our ability to purchase non-VA care. To best serve veterans, we need your help streamlining VA's care in the community systems and programs. We need your help to modernize and clarify VA's purchase care authorities to maintain veterans' access to timely community care everywhere in the country. We provided detailed legislation addressing this challenge over 9 months ago. I've consistently identified it as a top legislative priority. Above all, this needs to get done in this Congress to ensure a strong foundation for success and access to community care. The budget proposes a simplified, streamlined, and fair appeals process. In 5 years, veterans could have appeals resolved within 1 year of filing. The statutory appeals process is archaic and unresponsive. It's not serving veterans well. Last year, the board was still adjudicating an appeal that originated 25 years ago and had been decided more than 27 times. Legislating a simplified process can save over $139 million annually beginning in 2022. We compete with the private sector for talent, especially in healthcare. So we're proposing flexibility on the 80-hour pay period maximum for certain medical professionals. And we're proposing critical compensation reforms for network and hospital directors. Likewise, the Title 38 SES proposal we're working on is about treating VA career executives more like their private sector counterparts. It's private sector flexibility that attracts top performers, and it's not about firing people. The budget proposes appropriations language for general transfer authority that allows me some measured spending flexibility to respond to veterans' emerging needs. We need congressional authorization for 18 leases submitted in VA's fiscal year 2015 and 2016 budget requests, as well as authorization for 8 major construction projects included in VA's 2016 request. We need your support for 6 additional replacement major medical facility leases in the 2017 budget. And passing special legislation for VA's West Los Angeles campus will get positive results for veterans there who are most in need. This Congress, with today's VA's leadership team, can make these changes and more for veterans. Then we can look back on this year as the year that we turn the corner. I appreciate this opportunity and the support you've shown veterans, the department, and the My VA transformation. And I look forward to your questions. Thank you.
Thank you, Secretary McDonald. Mr. Secretary, as we've discussed, in my view, that the VA would serve veterans better if it contracted more with existing private providers rather than try to establish an in-house capacity for medical treatment when VA may have problems getting adequate staffing or is located far away from where the veterans live. The RAND Corporation assessment of VA care that was mandated by the Choice Act found that through 2019, the demand for VA services may outpace supply, but from 2020 onward, demand for VA care will level off or decline. With this changing landscape for likely demand for VA services, does it really make sense to continue to build up VA infrastructure capacity and staffing? You know, by the time you built the facilities and hired all the doctors and other medical staff and allied professionals, the hospitals may be half empty and staff underused. The RAND assessment noted a problem with the way that VA is approaching its future plans for providing care. It seems like VA has chosen the route of increasing everything from both community care and VA direct care without a long-term strategy defining what the balance of these approaches should be and whether the VA's role is predominantly the provider of or the payer for medical services. Do you have any thoughts on that, or are you waiting for Congress to mandate the strategy?
No, Mr. Chairman, we're not waiting for Congress. Our vision of a long-term VA system is an optimal system of private sector and public sector partnerships. We currently partner with DoD, Indian Health Service, Department of Defense, Indian Health Service, Alaskan Native Health Service, our medical school affiliates, which is a system that Omar Bradley set up in 1946 and has served us very well as private sector partners like TriWest and HealthNet. I'm going to ask David to talk a little bit about that in a minute, but I want to make sure I deal with one thing, and that's demand. While that study did say that demand would wax or wane for a period of time, would go down for a period of time, it's going to go back up. The problems in 2014 that created the crisis for the VA were not because of the wars in Afghanistan and Iraq. They were because of the aging of the Vietnam veteran. 2.5 million veterans over the age of 65 in 1975, 10 million veterans over the age of 65 in 2017, a 5 times increase. VA is the canary in the coal mine. We see the problems in American medicine before American medicine sees them. The aging of the Vietnam-era veteran is what created that demand. So my point is, if we don't build the capability today that we're going to need 40 years from now, when the Afghanistan and Iraqi veterans need the VA, when they turn 65 or around that time, we're not going to have it. So we need to make sure we build this optimum network in order to serve veterans long term.
Yes, excellent question. It's exactly what we spend a lot of time thinking about. VA does work with the RAND Corporation very closely, but we have a very sophisticated model for projecting enrollment called the Veterans Enrollee Projection Model. And basically what it says is your numbers are correct, but what the Secretary is referring to is younger veterans coming out of the recent conflicts actually are more service-connected and have much more intensity in terms of their needs of services. So our projections aren't necessarily for larger numbers of veterans entering the system. It stays relatively flat, increasing up to about 1% over the next 5 years. But the number of services that we project that they're going to require, that they need, actually goes up. It does change the configuration of the VA healthcare system. We agree. We think we're going to need less inpatient beds, but greater ambulatory or outpatient capacity. I think finally, we recognize VA can't do this alone. We are embracing working with the private sector, working with the local communities. That's why we submitted in October of this year the new Veterans Choice Plan on a way that we believe we should be working with the private sector for decades to come.
Quick follow-up on that. I do understand the intensity of the returning veterans with their with their issues are obviously very great. System-wide, what percentage of the veterans being served in the VA health system, particularly at the hospitals, are being treated for service-connected issues? It's my understanding in the hospitals in my area, about 40%, roughly, about 40% of those being served are service-connected. And it just speaks to the issue of, given the intensity of these injuries, that the VA must become more specialized, and that, you know, a lot of oncology services, cardiothoracic can clearly be done in the community very effectively, and we need to address that. Any suggestions?
Yeah. As I'm sure most of the members know, we have 8 priority groups for veterans, and I think the number that you're talking about, but unless the secretary or somebody else has the specific numbers, we'd be glad to get them to you. But I think about the percentage you're talking about are in the highest level, service level 100% connected. But throughout the various priority levels, veterans have percentages of their problems that are related to service-connected issues. So, so we are providing the type of care that's necessary, depending upon the level of service connectedness, and that depends on their benefits, that how much VA pays for and how much the veteran's responsible for.
Mr. Chairman, if I could, I just want to add that VA was already using community care prior to the Choice Act. In fact, when the crisis occurred, we provided about 7 million more appointments versus the previous year. 4.5 million of those were care in the community, and most of those were prior to the Choice Act. So we are believers in using care in the community, and we need to, as David said, because otherwise we won't be able to meet the demand. And one of the things we've seen recently is as we provide better care, the demand for that care increases.
Thank you, and that's, well, I won't belabor the point, but, you know, we also have to realign the incentives to make it easier for people to go out into the community. That incentives aren't quite right. But let's go to our friend and ranking member, Mr. Bishop.
Thank you very much, Mr. Chairman. Mr. Secretary, as you know, you are requesting an additional $1.7 billion for medical care in 2017. I understand that budgeting 2 years in advance is tough and that priorities can change. But in the FY17 second bite of the apple, you requested an additional $840 million for hepatitis C, bringing the total to $1.5 billion. Hepatitis C is a known priority, so why was it shortchanged in the advance? You also included non-recurring maintenance in the second bite, which to me looks like that number was used to pay for Denver. And I noticed that Vista Evolution is reduced by $40 million. My concern now is that the VA is purposefully underfunding priorities in the advance and using the second bite to fix problems that should have been budgeted for. Can you explain how you set those priorities in the advance request and what metrics you're using for the second bite, and whether or not we will continue to see the second bite grow each fiscal year?
Thank you, Ranking Member Bishop. That's a very good question. I think hepatitis C is a case in point. It shows the difficulty of trying to budget. You may recall last year we came back to our authorizing committees for permission to move money from the Choice Act budget to our internal budget because of the invention of a drug that we didn't predict. It's very hard to predict the invention of a drug 2 or 3 years before the budget actually becomes actual. And in the case of hepatitis C, we have had a plan to virtually solve hepatitis C for veterans within 5 years. Now, because of a new drug that's come on the market, some more competitive pricing, David and I have been talking about how do we accelerate that and actually cure the disease for all of our veterans before that. But what we've been asking for and what we would like to have is some flexibility to move money from one account to another so we can get after these things. Certainly, I can ask LaVerne to talk about, in terms of NMR, let me talk about NMR. As you know, 60% of our buildings are over 50 years old. NMR becomes non-recurring maintenance becomes a very big issue for us. We've got to, you were talking about the influx of and the increase of women veterans. Many of our buildings were built during a time when single gender restrooms were acceptable. We even have some of our hospitals that have communal living. They don't even have single rooms or double rooms. And in fact, David, you have the numbers on that. What are the numbers for that?
We have over 1,000 rooms in the VA system that have 3 or 4 beds in a single room that share a bathroom.
And for an all-volunteer army, when you're trying to attract, or an all-volunteer force, when you're trying to attract people to that armed forces, to have those kinds of standards that are archaic are no longer acceptable, I think. You want to talk about VISTA?
The reduction in VISTA was really driven around the fact that VISTA Evolution, which was created in 2014, was really to deliver modernized VISTA capabilities. For 2017, the budget for V was focused on investments to further expand our interoperability with DoD and the community providers that we now have to interface with. We continue the development of our enterprise healthcare platform, primarily around some of the clinical needs that we need to address, and making sure that the JLV, or what we call our Joint Legacy Viewer, would be in place in order to meet our NDAA expectations from 2014. What Dr. Shulkin and I decided to do after having a full review of the business case of VISTA was to focus this team primarily on those things that would enable that interoperability and also enable some of the clinical needs that were needed. But we also wanted to take a step back and look at what we really need to have an EHR as well as a healthcare system do. And as you mentioned here already, there's multiple needs that have occurred that are different than those that were even looked at in 2014 around women's health, around the area of the Internet of Things, which is now creating a very different point of view as how we deal with healthcare, but also how do we manage choice and how do we manage care in the community. So those are the things that adjusted the VISTA cost, but they also will come back when we come back with the new strategy.
Chairman, may I ask a follow-up quickly? Please. It's my understanding that, as you indicated, that VISTA modernization is now taking a pause, but that should not affect the interoperability, isn't that correct?
It does not affect the interoperability. In fact, we are on schedule to define a clear interoperability with DoD here in March and have an electronic key capability between EHMP and DIMSUM by August of this year.
Has the money then that we appropriated for modernization of VISTA been a complete waste? And what are your plans moving forward? Explain how this will not affect the interoperability.
Actually, the interoperability will be met. We will achieve the needs that we have with DoD and increasing the interoperability of the data between ourselves and themselves. In addition, beyond the EHR modernization that was part of VISTA, it actually included some critical investments in systems and infrastructure, supporting not only interoperability, but networking, infrastructure sustainment, a number of the continuation of some of the legacy capabilities and upgrading those to ensure they were secure and that we had security put around them that was appropriate, as well as ensuring that we had clinical terminology standardization, which is a key part of being able to have care in the community or interface with care outside of the VA. So the dollars that were in the VISTA Evolution were primarily focused on not only interoperability, but also the sustainability of VISTA and allowing it to grow.
Mr. Ranking Member, I just want to remember when we were together at Martin Army Hospital in Columbus, we're going to be using 18 specialists from Martin Army Hospital to treat veterans. That kind of use of DoD and VA facilities simultaneously could not be done without interoperability, so that's critical to our success.
And I think one side note, if I may, the JLV is at a point of well over 35,000 users, which is well ahead of where we had planned on it being used. So we're well ahead of our goal there, and it is available across the enterprise and being used by, at this point, well over 35,000 doctors.
Thank you. At this time, I'd like to recognize Chairman of the full committee, Mr. Rogers, for his questions.
to follow up on that line of questioning, some of you have heard me tell this, but it illustrates the point better than I can describe it for you. A young man came to me a few years ago in my office, a constituent, a veteran, had been injured in Afghanistan. He completely lost one eye. The other eye was severely damaged, but he was taken to the hospital in Germany. They operated. He came home as a veteran. The good eye began to deteriorate, so he goes to the VA hospital in Lexington, and they say, we can't do anything for you. We can't get your records from the hospital in Germany that DOD has. We just don't have access to that system. I'm sorry, but we don't want to operate because we're not sure what's in there that they did in Germany. So they turn him away, and he goes blind. That illustrates the point that Mr. Sanford Bishop has described better than I can tell you. Now, this subcommittee began on a warpath on that very subject, and to try to force DOD and VA to merge systems, at least become interoperable. I forgot what year that was. It's probably 7 or 8 years ago. At least. And we've given you money. Money's no problem. But I just fail to see how we can not do this quickly. I've watched the demonstration that we had a year ago or so. It looked like we were headed the right way. But I'm told now that DOD has awarded a $4.3 billion contract to a company called Leidos, Inc. for a new electronic health record. What does that do to this move toward interoperability between VA and DOD?
First,
Simple words, simple
Sure.
language.
First of all, I think the situation you described of that young veteran that happened several years ago would not happen today. We, as LaVerne said, we do have the capability, we do have the joint viewer, we do have DOD VA facilities all over the country, San Antonio, Chicago, and Lovell. The ranking member and I were together at Martin Army Hospital. So the situation you describe strikes me that would not happen today.
In fact, to put it at rest, as EHR, as you think about it, the interoperability is really around the data and the ability to view the data, the doctor to leverage the data and to understand the context of what was going on with the particular patient at the time so we can be clear about what we can do for them. This Evolution program has continued to build on the JLV, and the next generation electronic capability is called eHemp. eHemp is really what we're leveraging to pull the DIMSUM product, which is the DOD product, and align it with our product as an integrated grouping. So our data is fully interoperable, and our data will be able to be fully claimed that in August of this year, as we had scheduled and planned. In particular, by the end of this month, we'll be able to say that we are fully mapped to the same level of data with DOD and that this information is shared through that JLV. As I mentioned, with well over 35,000 users, we will be well ahead of our goal, but anytime anyone needs a record, at this point, they can get it as it relates to that veteran and understand how that veteran was treated outside of the VA.
And it will provide, you would be able to find records of past treatments?
Yes.
Where it may have occurred?
Yes, yes, sir.
Well, it's just absolutely insane for us not to have a system that links veterans' benefits programs, health programs, with what happened in the active military.
Yes.
That's elementary.
You're correct, and we're actually going one step further by looking at all data related to the veteran. We have an ability to look at those that are in active service today. We utilize that information to understand what we need to do on our benefits, and we're looking holistically at the veteran, not just at health, but all the benefits that they have rights to, and ensure that we have the right data at the right time. Bringing it together with vest.gov, but also bringing ourselves into the 21st century with the enterprise data management capability.
You were working to modernize your existing Vista record, DOD contracting for a new one, but I understand now, if I hear you right, that you're reconsidering modernizing Vista and thinking about acquiring an off-the-shelf product. Is that right or wrong?
Sir, we are actually, Dr. Shulkin and myself were not here during that time of that decision, and we took a step that said we were going to be good stewards of the use of those dollars. We did a business case around Vista. Based on that business case, our question was, could we enable the future around women's health, around care in the community, ensuring the security, and also increasing the mobility that's required within medical care today? When we looked at the issue, we felt that we need to take a step back and get the team to continue focus on interoperability, but also ask ourselves a question. What will it take to support the needs in the future, and what will it take for us to have a secure, capable healthcare capability that we can grow upon, not just in EHR? And so we are in the current process of looking at what that is. It could be an upgrade to Vista. It could be an alignment to use it as an EHR and figure out the best of breed processes to
Look,
reach those other venues.
We've been at this 10 years. We've been at this 10 years. We've given you billions of dollars. And I'm hearing muckety-muck here. I don't know what you're saying. Apparently you're saying you've not made your mind up yet about whether to replace the Vista system with something off the shelf. Is that right or wrong, yes or no?
We have not made our minds up, sir. And now let me tell you why. I think it's really important.
Be brief. Be right to the point.
I'm going to be right to the point. The fact is, we need to ensure that we have laid out the plan and strategy so that everyone can understand exactly what we're doing and why we're doing it. When we came into these roles, we didn't have that strategy laid out. And it's important, if we're going to be able to say that we're good stewards of those millions of dollars, that we act like and put the plan there, and that's what we're going to do. And it's not going to stop anything that's currently being done. Everything that's being done is not being done in a wasteful manner. It's being done as expected and as promised. But we are also going to lay out a format that's going to allow you to understand exactly what IT is spending their dollars on,
Well, the
what the VHA
Secretary
is doing.
tells us that what happened to my young man would not happen today. Is that right, Mr. Secretary?
Yes, sir, that's what I said.
But I'm hearing that you're having second thoughts about the system that you're headed toward here. Is that right?
No, sir, that's not what I'm
Dr. Shulkin,
saying.
do you have an idea about this?
Yes, I do. First of all, I completely agree with the Secretary. I actually now practice in the VA health system, use the Vista record. I completely agree. This would not happen. We can absolutely get records from the DOD using the joint viewer. That is being done today. 35,000 clinicians are using that. We are moving full ahead to make sure that Vista is an optimized system. As Ms. Council said, we are not slowing down anything on Vista. We have millions of dollars to enhance this, but I think what Ms. Council is saying is we have the responsibility. Technology has changed so much. We have the responsibility to lay out a plan to make sure that the system that we're using now is going to meet the needs of veterans for the future. And that's what we're doing, not slowing down. We're using Vista. It gets better every day, but we are looking at this once again, and I think that's the role why we came into these roles, to make sure that this is the right plan for veterans and the right plan for the American public.
Well, deadline is 2018. There will be no further excuses after that.
No problem.
This has taken altogether too long. I know it's complicated, and I know the Army, the active military have their own systems. You've had your own systems. We're trying to, apparently we've got a sort of an intermediary thing that can decipher both at the moment. But I'm not peaceful about this. I'm restless because the young people that we're sending over there deserve that we not let bureaucracy stand in the way of their health.
We agree with you, Mr. Chairman. The three people sitting in front of you here are not from bureaucracy. They're from the private sector. LaVerne was the CIO at Johnson & Johnson and at Dell. But what we have to deal with, too, is the comments Chairman Dent made about interoperability with the private sector. Remember, we're going to be sending more and more veterans to the private sector for their care, and we need to make sure that interoperability that we've been working on for DOD is similar with the private sector. And that's a big change. But we will stay on this. We will brief you whenever you would like and make sure that we take advantage of the committee's wisdom as we move forward.
Thank you. Keep us posted.
Yes, sir.
Big time importance to us.
I understand your frustration, and we will keep you posted.
Thank you.
Thank you, Mr. Chairman. At this time, I'd like to recognize the ranking member of the full committee, Mrs. Lowy.
Thank you, Mr. Chairman, and thank you, Mr. Secretary. Before I proceed, I just want to say this has been a bipartisan concern of this committee, and I cannot tell you how many hearings, how many closed sessions, and I know of your past career at Procter & Gamble, and maybe you can share with us at another time the same kind of confusions the private sector has. But frankly, whether you're a Democrat or Republican, we have not been able to understand why interoperability has been so difficult. So I thank you. We look forward to your success, and I want to proceed on another question that I've been concerned about. I know that the VA facilities have traditionally treated the needs of men, but we all know that the VA needs to adjust to the 21st century and make sure it meets the needs of female veterans. I've mentioned to you, Mr. Secretary, the story of one of my constituents who went to the VA medical facility in her third trimester of pregnancy, only to be told that they had never seen a pregnant vet there before and sent her away without the necessary referral. It's 2016, and the VA, as you and I would agree, should not be an unwelcome environment for female veterans. We need a bigger discussion on the types of care offered by the VA health system, Mr. Secretary. How inclusive do you see the VA health system in the future? To what degree do you feel the VA should offer non-service connected health care? And your budget request acknowledges the unique needs of women's health care and the ongoing efforts to improve female veterans' health, but what efforts are actually being made specifically to enhance access to obstetric and gynecological care for female veterans?
Let me first say, Ranking Member Lowy, that we agree with you that the increasing veteran population is part of our transformation of VA. We simply have to do a better job. You know, since 2000, the number of women veterans seeking VA services has doubled from 160,000 to over 447,000. That's a huge, huge sea change, and we have to do a better job with women. We have designated women's health providers at every one of our sites. We have put in place women's clinics at many of our sites, but not all. We talked about the importance of our non-recurring maintenance budget. 100% of our medical centers and 94% of our community-based outpatient clinics have at least one designated women's health provider. We've trained over 2,400 providers in women's health to ensure that they could interface with women veterans. We have women's veteran program managers in our sites. We have maternity care coordinators, and we need to hire more OBGYNs. We need to think about daycare. And an important thing, I think, for the committee is the fact that a veteran who was injured in combat and is unable to procreate can get in vitro fertilization service from DOD, but not from VA. And that's a matter of law. David, you want to?
Yeah, I just want to very briefly add, this is a great connection, Congresswoman, between the chairman's comments as well. So our enrollee projections show an increase in women veterans, so you're absolutely correct. We are laser focused on increasing services to women veterans, but we don't believe VA should do it all. So we are very focused on primary care and mental health services for women. We're growing our women-focused clinics in all of our VA medical centers and training more physicians and gynecologists to be there. But let's take maternity care that you mentioned. We don't believe it makes sense for VA to develop maternity services in our VA hospitals when we have great community hospitals in most of our communities that frankly do a lot more maternity care than VA does. So that's where we're developing these linkages. And those community hospitals have neonatal intensive care units that you need for high-risk women and deliveries. So this is a great example, focusing in on the services that women veterans need in VA, but working with the community for maternity services and neonatal intensive care.
Well, I appreciate that. In the last 58 seconds I have, we know that female veterans are 6 times more likely to commit suicide than women in the general population. And female veterans between the ages of 18 to 29 are 12 times more likely to commit suicide than their male counterparts. So I appreciate your views, and I look forward to hearing about the progress that's being made. Thank you, Mr. Chairman.
Thank the ranking member, and yeah, I'm glad to hear, Dr. Shulkin, what you said too about we really ought not be developing that kind of capacity within the VA system when there are so many good opportunities for women in the community as it relates to OBGYN services. So thank you for pointing that out. I'd like to recognize Ms. Valdeo at this time for 5 minutes.
Thank you, Chairman. Thank you, Secretary and guests for your time today. My first question, my office provides Central Valley Veteran Services to help them navigate the VA. Last week, a constituent in my office found out that a video conference request to appeal his case with the VBA was simply lost in the cracks. During our attempt to help him, we could not get a hold of anyone at the LA regional office where the case was assigned. Instead, we had to contact the Oakland office, which has always been responsive. They told us that the LA office had his request from a year ago, but failed to attach it to his file. My constituent has now been waiting for over a year and now must wait even longer. And this is not an isolated incident and shows a breakdown in record keeping. It is also a discrepancy in the quality of service between regional offices. In the time that I discussed this case with the IG, the VA has worked quickly to help this constituent out. But cases like this shouldn't require congressional action to get the problem solved. Mr. Pummill, why aren't there are systems in place to make sure requests like this don't fall through the cracks? And how can the VA better utilize best practices between regional offices to make sure quality of service is consistent?
We are doing exactly when the Secretary did his opening statement. We have a problem with our appeals process right now. The current appeals process that we have, it's set in law, it's lengthy, it's complex. It's just not fair. It's not fair to veterans at all. One of the things that we've done in the last year with the money that we got in for FY16 and the money we get for FY17 is beef up some of the areas other than the claims area. One of those areas is our call centers, the appeal centers, the non-rating areas. Both the Los Angeles office and the Oakland office. The Oakland office, the 15 people that we put there are already trained, and they're full up right now. The Los Angeles office are a little bit newer. To make sure that the offices are consistent, the same level across the offices, we're actually using the MyVA and the Leaders Developing Leaders program that the Secretary brought in. Directors here at Lansdowne the last 2 days. Part of that meeting, I brought them all in, and we had discussions on where we're going, what's happening, how to take better care of veterans, and how to get a better consistency when we're dealing with veterans. We're bringing in all, I'm sorry.
That's just a really long answer. I'm sorry.
Yes,
We've got a lot of questions we want to ask.
Oh,
but,
yeah.
but as far as you said, the process is part of law. Do you have any recommendations or bill ideas that we can to change that?
Yes, we do. We have some ideas right now. And next week, we are bringing in the Veteran Service offices and the state Veteran Service organizations. They're going to meet with us, and as a group, we're going to sit down and come up with a recommendation that we can bring to you to
Appreciate
change the
that.
law so we can do a better job.
And then as far as when you have a regional office like that with Los Angeles, when they're not responsive to congressional inquiries, what is the process are folks fired? I mean, do we do anything to these people for not responding when we're trying to take care of our constituents, the veterans in our district? I mean, is there a punishment of any sort? Because we always hear about the bonuses that are paid out, but I'm curious if there's a punishment when someone doesn't do their
As
job.
I said in my prepared statement, bonuses are actually down across the VA. That's purposeful because we're trying to match performance with reward. But yes, if you can let us know, what we've done is, since I've become secretary and Sloan Gibson's become deputy secretary, is we've put customer service in everybody's performance plan. And this is bad customer service. It should not happen. So please let us know about it.
Okay, and we will. All right, and then as far as my next one is, it's becoming clear that a major case of the VA's ongoing backlog is a result of bad scheduling practices. In October 2014 report, the Northern Virginia Technology Council found that the VA's current scheduling procedures are insufficient and unable to meet the needs of America's veterans. A recent GAO report on wait times confirmed this and showed that even more problems with scheduling, especially for mental health care. Last week, during a hearing before this committee, Deputy IG for the VA, Linda Holliday, stated that the VA needed to tighten up its scheduling practices. Secretary McDonald, can you talk about the problems you see with the scheduling process, and how is this delaying care for America's veterans? And I also understand that the VA has undertaken an expensive project to upgrade their computing schedule software. How are you working to better the human element of schedulers working with our veterans?
The majority of the problems that we've had with scheduling deal with really three things. Number one is the scheduling system itself dates to 1985. Let me show you a picture of it. The picture on your left is the current scheduling system. It dates to 1985. This picture does it too much justice. It's actually green screen. So imagine this screen being green screen. It looks like MS-DOS. Imagine being a scheduler at VA trying to do scheduling with this, and you can't move from one window to the other. In other words, when you go on one clinic, you're stuck on that one clinic. You can't get to another clinic. This is the change over on this side that we've put in place, which optimizes the user interface, and we can talk about that.
When did you put that in place?
Our very first clinic in Asheville, North Carolina, our women's health clinic, started to use it in January. It's about to go into New York Harbor and to Salt Lake City, and then in April, national rollout.
The second part of that is, of course, training the employees. The number of IG investigations that we've done on scheduling throughout all of our facilities found that the number one issue was not people deliberately trying to harm veterans, of course. It was untrained employees, and that's why we've invested in the training. That's why we had our people off-site, and we've really put time in investing in training. The third point is a lack of providers, and that's why we've hired over 1,400 more doctors, over 2,300 more nurses. We just didn't have enough people to serve veterans. So that should make the scheduling system much better.
At this time, I'd like to recognize the gentlelady from California, Ms. Lee, for 5 minutes.
Thank you very much. Good morning. Thank you, Mr. Secretary. Thank all of you for being here today. Let me ask you a few questions as quickly as I can. First of all, in January 2016, the OIG report found that the Oakland Regional Office continues to have, and let me just quote from this report, significant delays in processing claims, and that the management did not provide the oversight needed to ensure timely and accurate processing of informal claims, and included 1,308 identified back in March of 2015. And as a result, one of the recommendations is that the regional director provide training to staff on proper informal claims processing procedures and conduct a complete review of the remaining 1,248 informal claims. This has been going on and on and on, and we keep hearing responses that really don't measure up to what is actually taking place. So I want to find out, how are you going to hold the Oakland Regional Office accountable? Second question,
Let me answer this.
Okay,
We-
okay.
We did hold the regional office accountable. We have a new leader there, Julie Bohr. That report, that IG report, was about a couple of years old, maybe more than a couple of years old. Let me ask Danny to comment on what the Oakland Regional Office is doing today, because we've changed the leadership, we've improved the training, and I think the Oakland Regional Office today is performing as well, if not better, than our national average.
They are. Oakland is now providing better than national average. Julie's done a remarkable job. As recommended by the report, we actually stood down the entire office for a retraining on those work products. And I'm happy to tell you that right now, since Julie's got there, there's been a huge turnaround and 90% improvement in her work inside of the RO.
Okay, we're going to follow up with you on that.
Please, you're welcome to come down anytime.
Yeah.
She'd love to show you around.
Okay, second question, and thank you very much for that. The issue around PTSD, this was reported in the New York Times last week, and I want to know a little bit more about that. In terms of the vets with PTSD receiving less than honorable discharge from the military as a result of minor infractions from the military, and obstacles with those seeking an upgrade on their discharge. Of course, I'm concerned, I mentioned this at another hearing, that the burden of proof for PTSD, it continues to be on the veteran rather than on the VA or the military, and that the boards responsible for considering such appeals are really, they don't lack transparency and they're not staffed properly. So in terms of this effort, those with past PTSD claims that were denied, how are you addressing that and what are you doing?
Of course, the status of someone's discharge comes from the Department of Defense, and there's a mechanism in the Department of Defense to ask for a review. But this is the reason that we thought strategic partnerships was so important, our fifth My VA strategy. There are about 15%, 15 to 20% of veterans who have less than honorable discharges. By law, we are not allowed to serve those veterans. So we need strategic partners, people in the community. I visited an organization in Boston called Home Base. It's funded by the Boston Red Sox Foundation. They are a strategic partner of ours in the Boston area. So when we find a veteran who has bad paper, what we call bad paper, less than honorable discharge, we can send them to Home Base and they will be treated just like they would as if
Okay,
they
but
were
I'm talking about upgrading their discharge if they were denied.
That's a Department of Defense job.
That's DOD. Okay. The other, we'll talk to DOD about this then. Let me ask you then about your expenditures in terms of contracting. You spend a lot of money, and I just like a breakdown of your minority and women-owned contractors percentage-wise and how you break that down, and would like to review that for this committee.
Great.
And the other question or point I want to raise, because I'm going to see how we can work on this, I want to look at our veterans who are returning into civilian life, entering into civilian police departments. I want to look at the training, how you train them for that transition from war to working in civilian police departments. I've heard many times over and over again that many of the issues we have in the community as it relates to a lot of the distrust between communities and the police, a lot of the police misconduct could be related to improper training with veterans who come directly into the police force who have been in Iraq or Afghanistan.
I honestly don't think that characterization is fair. We have something called a Transition Assistance Program. It's roughly 120 days or more before someone departs the military. We put on an event at the post. The commanding officer, general or admiral, helps us. At that event, we get people signed up for their benefits. We explain what VA does. We also have a job fair, and we get them signed up for jobs. And it's been my experience through that, although this is anecdotal, I don't have any data yet, that actually the cities of the United States, many of the mayors want to hire veterans.
No, I'm not mischaracterizing this. I'm just saying that it's my understanding from talking to many that the training and the transition has not been adequate in terms of the skills and in terms of what's needed to work in the police force in a community in the United States versus coming straight, versus in Iraq or Afghanistan.
I think the transition we're doing today is better than ever before. We have 250,000 service members leaving, and what we want to make sure is that those individuals have jobs and are trained for those jobs before they leave the military.
Sure, and I just want to make sure they were trained properly.
Understand.
And that's what I'd like to get information on. Thank you.
Thank you. Thank you, Ms. Lee. At this time, I'd like to recognize the gentleman from Florida, Mr. Jolly, for 5 minutes.
Thank you, Mr. Chairman. Mr. Secretary, a couple quick questions. One, an update on the claims backlog. Last year, we had an exchange, and you testified before the committee that with 770 new FTEs, you felt confident you could eliminate the backlog. Can you give us an update on that?
Yes, sir. We've gone from about 611,000 at the peak in 2013. Now we're down to 80 to 75,000. Danny, do you have today's update?
Yes, about 82,000.
About 82,000. The majority of those are difficult ones where we're waiting for a piece of data. Can you characterize the ones that are left?
Yes, we will always have a certain number of claims. Use this one. I'm sorry. Sure. We have a broken microphone. We're always going to have a certain number of claims in the backlog. There are certain claims that are just so complex, or because of trying to find records, mostly for older veterans, Vietnam-era veterans, it's going to take longer than the average claims. So we're going to have some claims that are always going to be over 125 days. We estimate that number will be around the 60 to 80,000 mark.
So for the Secretary, do you feel we're on a pathway to eliminating the functional backlog, if we want to call it that?
I do. My big concern right now, Congressman Jolly, is the appeals process.
Right.
We have over 400,000. We have 440,000 appeals that we've got to solve. The only way we can solve that is with new legislation.
Right, and that's my next question. But I want to zero in on this because last year, because look, the claims backlog is as significant as the VHA issue of 2 years ago. Frankly, I've said this over and over. If Anderson Cooper decides to do a story on the claims backlog, we're going to have the same outrage in the American public. And I appreciate what you're doing to try to solve it. And the solution you presented last year was 770 new FTEs. We agreed to honor that request. I want to make sure that you believe we're on the pathway, because I know this year there's an additional request for more FTEs. I presume that's just because of growth of claims. Is that right?
That's correct. We've gone from roughly 950,000 to over 1.3 million a year. So it is the growth of claims.
So but you still stay on the FTEs are the issue, is that, or the solution?
They're a
In
partial
addition.
solution. They're a partial solution. Obviously, taking the system to digital from paper has been a big deal.
Right, right. And so then the overhaul of the appeals process, can you kind of briefly describe what that overhaul would look like that would help on that?
We have put a straw man piece of legislation, our budget proposal. We have 100 of those, 40 of which are new. One of them is the appeals process. But as Danny said earlier, we're getting all the veteran service organizations, congressional staff members, state directors of Veterans Affairs together. We're going to lock everybody in a room. We're going to slip the food under the door, and nobody's going to come out until we have something written that everybody agrees with, or at least we identify those that disagree, that we can bring to you and it can pass immediately.
Well, thank you for doing that. And I understand that's coming up, right? That meeting is
Next
actually
week.
next
Right,
week.
next week.
Okay. And second or third question, you and I have also spoken in the past about the nursing handbook and whether or not there would be any changes in the nursing handbook that would conflict with the requirement to have anesthesiologists overseeing any of the work. And the committee's been pretty clear year after year after year after year on this issue, including last year with report language suggesting that no changes should conflict with the current anesthesiologist handbook. I know a proposed rule recently went to OMB. Can you maybe describe your position on this issue?
Yeah, our point of view, and David shares this point of view, is that of all the things in the nursing handbook, the new nursing handbook with expanded responsibilities, expanded duties, the thing we feel least comfortable about is anesthesiologists. So,
Congressman, what I think we're talking about here is the CRNA component.
Right.
And we believe that the teamwork-based model in anesthesia right now is effectively serving veterans. The most important thing that we're trying to address in the handbook is access to care.
Sure.
We believe full practice authority for nurse practitioners will be very important for us to expand primary care access.
But wait,
we are taking
doesn't that conflict with what you just said, though?
no primary care access. With
Okay.
CNRAs, we feel that the current system is addressing access adequately.
So you support the existing anesthesiologist requirement in the handbook?
Right now, and we spent some time with the chairman and ranking member on this yesterday. Right now, in the VA, we believe that the current system is serving veterans adequately and safely. We do think that in the future, we may have to take a look at this, that if access does become a problem, that's a different issue. Right. And so in the future, we may have to look at this differently, but right now, we believe it's serving veterans adequately.
And that's your viewpoint as well, Mr. Secretary? All right. Thank you. Mr. Chairman, thank you.
Thank you, Mr. Jolly. At this time, I'd like to recognize the gentleman from North Carolina for 5 minutes, Mr. Price.
Thank you, Mr. Chairman. Welcome, Mr. Secretary, and your colleagues. We're happy to have you here. We appreciate your work, and I'd like to turn to another area that's of great importance. It's an area of in your budget that I think would not be replicated anywhere else in the federal budget were it not done by the VA, and that has to do with the particular focus you have on a certain kind of research, medical and prosthetic research. You're asking for a modest increase in your research budget, totaling $663 million. You make the point in your presentation that this is not the whole story, and I'd like to, that may be elaborated somewhere. It was not elaborated in the material I saw. You said that this was supplemented by $1.3 billion, actually, from VA medical care for a total of over $2 billion in the research budget. So it's not completely clear to me what that refers to, and when you describe your research program, what comes from which budget line. Now, when you talk about what the increase you requested will support, you're talking mainly, as I understand it, about two genetic medicine initiatives. One, what you call the Precision Medicine Initiative, drawing on the Million Veteran database, and then secondly, additional analysis of DNA specimens from that source. So, two questions. Can you clarify what kind of money we're actually looking at here and where it comes from? And then secondly, what stock you place in the increases you want and the ventures it'll let you make into genetic medicine? And then I guess finally, if more funding were available, what would be the next line of research initiatives that you would aspire to?
Congressman Price, you raise an incredibly important point. The VA has been the source of innovation for American medicine, whether it's taking an aspirin a day to avoid a heart attack, the first implantable pacemaker, the first liver transplant, the first kidney transplant, working on heart disease. And I haven't even mentioned injuries from warfare, but these are things that have happened at the VA. 3 Nobel Prizes, 7 Lasker Awards. VA research is essential. You asked about prosthetics. Last week, we did the first 2 operations in the United States, something called osteointegration in Salt Lake City, where we actually put a titanium rod in the veteran's bone and then attached the prosthetic device to it. One of those 2 veterans last week, when they walked for the first time, said, "I can now feel the grout cracks between the tile." And the reason for that is the nerves grow around that titanium rod and give it the sense that you would have if you had your leg. And so this is incredibly important research. Last week, we also announced with the President our work on the Million Vet Project, this genetic engineering, the fact that we have right now 450,000 blood samples. We're going to have 1 million, one of which is mine, and we have 40 years of medical records that back those up, which is a gold mine for researchers to figure out how genetic changes affect disease. And we had on the panel with us a veteran who had suffered uterine cancer, but because of us understanding her genome, we also know she is susceptible to colon cancer. So we've increased the rate of her colonoscopies to save her life.
Congressman, 90% of VA researchers have academic appointments with the leading medical centers in the country. The VA research, as you know, is dedicated exclusively to helping veterans. It's actually, I think, the best investment that the American taxpayers have. So the $663 million is provided by the U.S. government. The $1.3 billion that you're talking about is actually extramural funding. It's competitive funding that these researchers have gotten to support research. So together, it adds up to that large number, the 1.9 billion.
The extramural funding coming from NIH, NSF, and also non-governmental sources?
And non-governmental sources, all three, yes.
So this isn't exactly leveraged funding, but it's funding that, for practical purposes, is combined with
exactly.
your base.
Exactly, much like an academic center would count its research funding, yes.
Of course, Duke University is one of our best medical school affiliates where a lot of research occurs.
You said it, Mr. Secretary. You said it for me. Thank you. Thank you, Mr. Chairman.
Thank you. At this time, I'd like to recognize the gentleman from Ohio for 5 minutes, Mr. Joyce.
Thank you, Mr. Chairman. Secretary McDonald, from one of your prior answers, I've got to ask, do you receive a bonus?
No, sir.
Why is it acceptable for anybody else to receive a bonus in your organization if you're paying them a fair wage? Wasn't that part of the problem that we've had with people scamming the systems to achieve their bonus before you took over, sir?
Congressman Joyce, given my experience at the Procter & Gamble Company, I would tell you that for similar work, that bonus becomes an essential part of fair compensation for government employees. Government employees typically are not paid. Our medical center directors are paid half what they would earn in the private sector. So that bonus becomes, in a sense, part of their compensation, and they look at it that way. What we have done, as I said earlier, is tying bonuses to performance. We've actually reduced the spending on bonuses in the department. And we also have a distribution of rankings which matches the performance of the department. So I think we've got that under control. But I would hesitate to take away the bonus unless you increase the compensation.
Well, maybe that's what we should do. Pay a wage that is consistent with the industry, so I get the best and brightest to be there at the Veterans Administration, so they're taking care of the veterans. Wouldn't that
bonuses are another way to differentiate. At the Procter & Gamble Company, after about 6 years with the company, you would be eligible for a bonus program. So it's what's done in government isn't out of question with the private sector. It's not totally inconsistent.
I get that in the private sector, but in this sector, it just, again, it was one of the causes for why people were scamming the system, if you will, to receive the bonus, pay the wage, and hold people accountable to the wage that they're being paid. And if they're not doing it, then they should be fired. The OIG was in here the other day, and they said they'll take cases where they find people stealing money, and they take it to the federal government, and if the DOJ doesn't do anything with them. I said, well, why don't we take them to state prosecutors?
And us as well. You know, since I've been secretary, we have separated more than 2,600 employees, and that doesn't include over 500 who have chosen to resign or retire ahead of that. So accountability is incredibly important. We can't change the culture without holding people accountable.
And don't get me wrong, sir, I think you're a good and decent man. I think that you needed to be evaluated when you took this job because you were on the things you were doing in the private sector. I certainly appreciate your service in coming here and providing those.
Joyce, as you know, I'm not doing this for the money.
I certainly got that, sir. And so that's why I couldn't help it from one of those other answers. I had to deal with that. Speaking of solutions, following up on my gentleman from Florida, you talked about the backlog. You know, other agencies have used private contractors to help process that backlog to get current. Is there a reason? I see you put in money for full-time equivalents, but again, once you process the backlog, you really need those people. And so I was wondering when and if your agency was contemplated that, and if in fact they were going to use it.
That's actually an interesting idea for our team that's getting together next week, because so much of the appeal is written into law. It's a law that's about 80 years old. Doesn't allow for private contractors.
Okay. There's one of the solutions we could provide for you. Following up, another thing that you touched on before was mental health issues. I want to know when you talked about an external partnership that you have, and I believe that was the Boston area you mentioned with the Red Sox.
Just one example, we have many, including our medical school affiliates.
You know, the access to mental health care is important. I don't think somebody who calls you and says that they have an issue should have to wait 30 days to find somebody. Have you thought about how we're going to do that? Because these men and women who put their life on the line, they're obviously coming home and having some issues. How can we make sure that when they make that call, they're receiving the treatment that they need?
One of the things that we've done, and we've worked very hard on this, is to modernize all our crisis lines, as well as to make mental health care available 24/7 at all of our medical centers. This is critically important. We can't wait. And as you know, we brought in some, because we've reported this publicly, we brought in some new leaders of our crisis lines, people with experience. We brought in a lady who had run Philadelphia's 311. So we're applying private sector principles and methodologies. We're also updating the equipment. And David, why don't you talk about the hospitals?
Yes. Thank you for mentioning this. This is one of our key issues. As you know, our best data today, but we hope to update this in the next month, is 22 suicides a day among veterans. 17 of
22 too many.
22 too many, absolutely. 17 of them do not receive care in the VA system. So we're actually working now and reaching out to community.
Mr. Chairman, Mr. Joyce and I'd like to publicly invite you out to the opening of the first DOD VA designed clinic at the former Fort Ord on October 14th.
October 14th. I've got it on my calendar.
We have a pay increase of $1 million. And this is where the comment is, you guys just don't pay your incredibly hot, great staff what they deserve. And I think the only way you can keep people like Lisa Freeman is to get a bonus. So I don't think we're going to change the whole salary structure. So I think it's a great issue. We've got to just, we want to retain talent. And
Arson, we have, I'm sorry to interrupt you, but I just want to let you know, we have suggested that we take people like Lisa, who are currently senior executive service, to Title 38, which would give us a lot more flexibility to pay her competitively.
do you need that legislative approval?
Yes, sir, we do,
authority?
and we've given the prototype bill to both our House and Senate authorizing committees, and we'd appreciate your support.
Thank you. You have it. One of the, we have Palo Alto, which is an incredible center, and then I'm hundreds of miles away, and so we're in a rural part of the area, and this clinic is really going to be interesting. But what we're finding is, one, we can't get psychiatrists to take the salary offered and to move in that area. We have created in California, because of leadership of a judge in Santa Clara in Silicon Valley, named Judge Manley, who created these veterans courts, and he's sort of the guru of it. He tells me that they don't, he won't refer. What he does is he gets, all these problematic people, and what he says, I just bend the law. He says, but I'm working with all the social service, ACLU, and everybody, and I don't put people in jail. That's what he tells me. He's a former prosecutor. I don't put people in jail. And he says, even with some serious crimes, I don't put them in jail because jail is not going to cure their problem. But I do get them in treatment programs. He says, the problem with the veterans is that the wait is too long. It's an archaic system of treatment. He says, whereas the counties have really come into sort of handling this stuff on the sort of on the civilian side. He says, well, I sentence my people to the county system. He said, even with the great Palo Alto Veterans Hospital, it's the system, and I wondered whether you need any authorities to sort of modernize that system, because the last thing you can do, like intervention, is people say, okay, I'm ready, I'm going to take this, and I'm going to go try to get treatment, or I'm drug. You can't say, well, then you got to wait 30 days to a year for a placement. It's got to be immediate.
No, you're absolutely right. Veteran treatment courts are perhaps the biggest innovation positive for veterans over the last 5 years. We've gone from virtually zero to now, I think we're over 300, maybe a little bit less than 300. And in every case, Veterans Treatment Court keeps veterans out of jail and puts them into care, and going to jail, incarceration is a one-way ticket to homelessness.
Yep.
So it's a great investment to eliminate homelessness to do these veteran treatment courts.
Your judge's experience is the first I've ever heard where in some area of the country, we're not providing the caseworkers who are providing the care in the right way. And
His point is that the backlog is so, in the veterans system, is too long.
We're the largest employer of social workers in the country. So I mean, I want to dig into this one with you.
Well, the point I'm trying to make is, I think Ms. Joyce or others brought it up, is that these veterans who are going to local hospitals and going to sort of in the civilian world of medicine treatment and mental health treatment, we ought to allow that to happen.
Oh, for sure.
Where there is a backlog, where there's immediate sort of the emergency. Because what's happening, and this is the second part of that, is when our veterans do end up in an emergency room, they're being charged by the hospital in their own personal account, and the reimbursement takes so long that they end up with credit defaults, which then go on their record, and it just screws them up from then on because, you know, VA didn't.
We agree with you, and one of the things we're also pursuing is in our consolidation of care bill that takes these 7 different ways of getting care in the community, all with different reimbursement rates, all with different criteria. Combining those into one of the things we've got to look at is the reimbursement of emergency room care. Right now, this is a big problem for veterans because they have to be pre-cleared, in a sense, to go to private emergency rooms. So that's part of that bill, and I think that's something we need to deal with.
Shortening the wait lists and all of that. The other one I've talked to you about in my office is that you have a strange system of authorizing people for hire for marriage and family certificates trained by states, that they have to go through a certain accreditation process. And I understand that's not just true with marriage and family therapists, it's also true in a broader sense. Are you looking at the ability for VA to broaden your ability to hire behavioral health providers and others outside of that just one-size-fits-all accreditation? I mean,
Yes,
University of California, Berkeley, Stanford, getting licenses in California can't come work for you.
Right, good schools. We are looking at that, David.
You're absolutely right. We do have a shortage of mental health professionals, and we do want to have people join the VA. We are looking at the criteria and the curriculum of the California schools. The Secretary has asked me to personally look into this. I will get back to you.
It may look for other professional providers as well, as you have that strict accreditation requirement.
Yes.
Thank you. This time, I'd like to recognize the gentleman from Florida, Mr. Rooney.
Thank you, Mr.
For 5
Chairman.
minutes.
Thank you, Mr. Chairman. Mr. Secretary, I just want to feed off of something that Congressman Jolly was talking about. You had said that there are 600, you reduced the claims backlog from 675 to around 82,000, but now that there's approximately 400,000 appeals pending. I was recently speaking to the Florida VFW officials as well as Florida American Legion personnel, and one of the things that they expressed to me was that one of the problems is that the VA has moved personnel from the claims division to or from the appeals division to the claims to reduce the backlog in claims, but then that has increased the appeals backlog. So we've just, instead of trying to solve the problem, we've shifted that. And I said, well, why is that so? And it's because we have too many managers or supervisors or people in pseudo leadership positions in the VA as opposed to actual just worker bees to knock out these claims. Now, is that true in your opinion?
In my opinion, that's a red herring. I'll ask Danny to talk more about moving people, but let me put some facts on the table. 10 to 11% of veterans appeal. So that's a relatively small number. But because we've gone from 950,000 claims a year to 1.6 million claims a year, the absolute number gets bigger. Of those 10 and 11%, 2 percentage points, so 2%, create 45% of the appeals. So you have 2%
of the veterans, creating 45% of the work on appeals. And many of these appeals, as I said in my opening statement, have gone on for 25 years, 27 years, 29 years. It's just, it's unfortunate that 2%, and the majority of those 2% are already getting a disability payment and are already rated totally disabled. So, you know, we have an issue. We've got to deal with it, and that's why we're getting together next week. But Danny, have you moved people?
Just, if I could, just on that, if you feel like one of the things that we've talked about with you over the course of your tenure has been sort of hierarchy on your staff. Do you feel like the things that the VFW officials were telling me are accurate or inaccurate as far as you being able to sort of put the chain of command that you think works most efficiently for that organization, as opposed to, you know, getting stuck with the way that it's been and not being able to move the wheel?
Yeah, 10 of my 16 direct reports are new since I've been confirmed. Everybody at this table but me wasn't here last year to testify. Ron was on staff, but at a different level. Danny is the new leader of VBA. He's already made changes. I think you changed the chief of staff, if I'm not mistaken.
A new deputy.
New deputy, I mean, yeah. But could you talk about moving the people?
Yes, we have new deputy, new chief of field operations, and we're looking at the entire staff in the headquarters to move people around to positions where they're better suited right now.
Well, I'm not talking about moving around. I'm talking about if you've got a bunch of people that are supervisors or managers, and then, you know, they're all sort of telling each other that they don't have to do the work because they're in charge. And then you've got like 2 people there that are actually knocking out claims or figuring out what the appeals are. I got the sense from talking to these officials in Florida that the VA is still top heavy, rather than using the money and the resources that we appropriate to have personnel there that are better suited to just knock these claims out.
No, we have the right people doing claims. As a matter of fact, we're probably just the opposite. We put everybody on claims last year, from the highest person in the RO director, down to people that were sweeping floors. If they could help with claims, everybody was doing claims. Your question about did I move people off appeals? Yes, we did last year. We moved some of the people off of appeals and put them on claims. But even with that, I did 30% more appeals last year than we ever did before in our history. We did more appeals. Those people are all back now because we have our automation system in place, and it's working. So they're back on appeals. And last week, I directed $10 million only for overtime for people in appeals to get them on the appeals process.
Okay, I have to cut you off because I have 10 seconds. If I could just ask another question before Charlie gavels me down. I'm very sensitive towards my time. We also talked about with PTSD and TBI. We have some of the people that have come to see me and some of my constituents said one of the problems with the VA is that we are treating potential suicidal veterans with social workers. Not that there's anything wrong with social workers. I worked with plenty of them in a previous life. But when you deal with somebody that is potentially suicidal, and whether they are given a prescription from a therapist or being told to see a social worker versus going to see a psychotherapist or a psychologist, how do you kind of put who you diagnose with somebody who's potentially suicidal with the person that's most likely going to give them the help that they need?
Yeah, very briefly, excellent question. The field of mental health actually is a team-based approach. So there is a triage assessment, a risk assessment, and the higher level, the higher severity patients are assigned to psychiatrists. And then there are psychologists and social workers that are part of the team as well. So higher risks, a suicidal patient should be under the care of the most advanced level practitioner, the physician.
Okay, thank you, Mr. Rooney. I'd like to quickly follow up on something that Mr. Jolly and Mr. Rooney both were pointing out. They were discussing the VA claims backlog, and I was looking at these My VA charts, this page here, where we see in the bottom right corner that the number was 75,480. For your claims backlog, I think Secretary Bob McDonald, you started to address that, but for that claims backlog, what % are first-time claims? And you're correct when you say that some are already receiving some kind of a payment. It's not like they're not getting any money in all cases, but, and how many are maybe second, third, or fourth, or even more, as you noted in your testimony, you have a 25-year-old claim in the queue, so how many are first, second, third, fourth, et cetera? Maybe Danny or
Those claims, those are original claims. They're about half. They're about 50-50. About half of those are veterans that have already filed a claim and they're filing a new claim. The appeals are a different bucket entirely. They're not counted in this at all. Those are veterans that have filed a claim. The majority of them are already receiving compensation also, generally about 50% compensation, but they haven't appealed. They've appealed a portion of their claim.
I don't know if that was clear or not, but on the chart you have, that
about half, I guess, is what I heard.
that chart was only claims. That was not appeals. The appeals chart would be different.
Okay. Thank you. That's a good clarification. Oh, sorry, I have to recognize Mr. Fortenberry. I didn't see, I apologize. It's your time. My apologies. I didn't.
No, thank you for your deference, Mr. Chairman. Good morning, everyone. Good morning, Mr. Secretary. Nice to see you all. Appreciate it. Mr. Secretary, as you are very much aware, Nebraska is pre-positioned to help you build out a new VA Center of Excellence, a 21st century model for care for our veterans with innovation, with continuity of care for existing problems, but also enhancement for specialization. We're ready to enter into an innovative, unique public-private partnership that I think has significant implications for the future of the VA and the innovation that needs to take place with current medical facilities, tight budgets, and community goodwill. Can we do it?
We sure want to. I think public-private partnerships is the way of the future for us. And we need to, to prove out this model, and I think Omaha is a good place to do it. As you know, I think we've finalized the scope and the cost estimates for the project. We're talking about 157,000 square feet, including primary specialty care, radiology, ambulatory surgery. We estimate the cost will be $136 million or so, $136 million. We've got $56 million appropriated, but we're working hard to figure out what legislation do we need and how do we need to get this scored to get this done. And to me, those are the two things on the critical path, and we're working with you to do it.
In the old days, we put money aside and put it under the mattress until we had enough to build out something. It's not working anymore. We all know this. Now, there are public-private partnerships that already exist in housing and other areas of the government. We got a report from you. I received it just yesterday. We're having some trouble deciphering what exactly it means. But whatever authorization you need, whether it's in appropriations or through regular authorizing processes, we stand ready to assist you. There really is no reason not to do this because we're getting hung up on some of the nuances of accounting. The opportunity cost of not doing this is huge. So when will we have specifics on what you need to be able to empower you to move forward on this? I think that's the next stage answer that we need.
Yeah, I think we should have that done in a week and a half to 2 weeks.
Oh, great. Excellent. Well, that would be very, very helpful. As you are very much aware, if we simply, right now, I think what the problem is any community partnership, any private sector allocation that comes to you would be counted as a score, a cost to the VA, and this seems to be very peculiar.
If it's a leaseback situation, CBO and OMB have tend to score it that way.
Okay. So we're not necessarily in this case looking at a leaseback. We are looking at basically the community
I think
partnership.
that's why I think this one should lead the pack, because we don't have that constraint.
Yeah. Well, again, the opportunity right now, we've got about close to $60 million set aside. This has taken years and years to get that number. The projected build-out with public funds is so huge it would never occur. So we stand ready to fully partner with you, and the potential resources are there in the Omaha community. I think once a commitment is made, these numbers perhaps are a little bigger than the earlier estimates, but I would like to think that momentum would occur because there is such a deep commitment in the community to assisting the VA to what will be a new model policy innovation that I think has implications for the rest of the country.
Absolutely agree.
Okay, I like the answers I'm hearing, Mr. Chairman, so I'll yield back my time.
I have work to do.
That's a first today. Great, thank you. Secretary, we realized the uncertainty of making medical care estimates for a fiscal year 2018 advanced budget request, not knowing if veterans will continue to increase their reliance on the VA for care or where they'll seek care, you know, VA or care in the community. But your budget request for 2018 seems dubiously low. On a comparable basis, including choice, your 2018 request is below 2017. It would require cutting 13,500 positions and decreasing medical care by $4.4 billion. I don't think we've ever had a year-to-year decrease. I don't think that's ever happened at the VA. That portends an enormous second bite at the apple, if you will, in the request for next year's budget. It's not going to be much of a welcome gift for your successor. Why didn't the administration send us a more realistic advanced budget request for 2018?
Mr. Chairman, I think there are a number of things. Number one is we're trying to figure out this hybrid network that we're going to have between private sector and public sector. We're in the throes of doing that. Number two, as you know, the Choice Act funding goes away at the end of 17. We've got to figure out how we transition from that to a sustainable system long term. Number three, consolidation of care in the community. We've put in a proposal forward to our authorizers. There's a lot of uncertainty on that proposal, and we don't know, depending upon what our authorizers choose, whether or not they deal with the emergency room issue, whether or not they deal with the increased demand issue. We don't know what the cost will be. So I agree that there probably will be some more cost, particularly for care in the community in 2018. But any number we came up with would be a guess at this point. We'll have to work with you on it as we get more certainty.
Okay. Well, thank you. We look forward to maintaining that conversation or continuing that conversation. Let's go to shift to hepatitis C. As you're very much aware, the committee was very supportive of the need for additional funding for Hep C treatment for veterans and provided $1.5 billion in the 2016 conference report. Your 2017 second bite at the apple requests $840 million in order to maintain the program level, that program level of $1.5 billion in 2017. We understand that the price the VA pays for hepatitis C drugs has dropped. I think we discussed, I think I discussed that with Dr. Shulkin or some of the other staff. It has dropped. How many, from 40,000 down on average, about 20,000, I guess. How many cases per week will you now be treating using the 1.5 billion? And if the 1.5 billion level were sustained in the out years, how long would it take to treat the entire eligible VA population? Dr. Shulkin. Yeah.
Yes, Mr. Chairman, we believe that we have about 120,000 veterans with hepatitis C. Our original estimates when we submitted this were that we were going to be able to treat about 35,000 veterans a year. That would take us about 5 years. Now that there has been an adjustment, we believe that we can treat many more veterans. We believe about double that. So at about 70,000 veterans a year, which if you do the math would be about 1,300 veteran starts a week of new therapy. We should be able to eliminate the backlog in about 2.5 years. And as you know, about 95%, as you told me yesterday, this is a curable disease. This is one of the best advances that we've had in recent times. So this is great news for veterans.
It is great news, and it's, I guess, a little bit more complex now given the opioid issue and what we're learning about the the connection between Hep C and heroin abuse.
Yes.
And I don't know how that's affecting the veteran population, but I suspect it's affecting veterans as it is the civilian population. On the issue of disability claims, it's good the department is tackling the next looming backlog, appeals of initial disability claims. But I have to say that I'm a little bit skeptical that the authorizing committees will be willing to tackle the legislative provisions that are necessary to make your plan work, especially in the election year. It also seems unlikely Congress will be able to provide enough funding to increase your staffing from the current 680 to the required 5,100 to erase the backlog without legislative changes. What about the option of technology? The claims backlog has been helped immensely by the implementation of the Veterans Benefits Management System, which has made the claims process paperless. Is there something similar that could be developed for appeals? I'm not sure, Secretary, who should take that one. Maybe.
Well, I can answer part of that, Mr. Chairman. Part of it we're already in the process of doing, and that's doing hearings by video conference rather than personal appearance. And we've been able to convince our veteran service organizations that the conclusions of those are as positive as they would be with a personal appearance. So that has made us much more efficient with the limited number of judges that we have. I don't know how much farther we can go, though, using technology, given the way things are written into the law. Danny, could you comment, please?
We're getting ready to push the appeals into the VBMS system. That's going to help us a little bit. Short of some kind of change in the law, though, on how we do appeals, we don't see us ending the appeals backlog. Even if we threw people at it, we couldn't afford to throw enough people at it to solve the problem with the way the appeals legislation is written right now.
Thank you. My time's expired. I'm going to recognize the ranking member of the subcommittee, Mr. Bishop.
Thank you, Mr. Chairman. Mr. Secretary, I want to return to my reference earlier to the Board of Veterans Appeals. Your budget proposes to simplify the appeals process through legislation and provide additional resources toward that effort. Regarding authorization, it's very unclear at this point if the authorizers are going to take up the proposal. So my first question is, what benefit would be the increase to the BVA appropriation if the accompanied authorizing legislation is not passed? Then correct me if I'm wrong, but it appears that this proposal would limit a veteran from updating his file as it goes through the process. Will the veteran still be able to submit additional information, or is there a cutoff point under your new proposal?
Ranking Member Bishop, it depends how the group comes back with their ideas next week. The straw man that we have put into our budget proposals, the 100 proposals we have, is one that would freeze the Form 9, which means the individual would submit a new Form 9 with a new claim. Again, that's going to be looked at next week, and we'll have a better idea. I think, we have raised this. I'm sorry, sir.
Have you consulted with the VSOs to get a buy-in from them before you release the proposal?
Yes, we're working with them right now, and we're also working with the state directors of Veterans Affairs as well, and they will be part of the work group next week. But back to the legislation. I mean, I hear you and Chairman Dent both saying that you think the probability of us getting this legislation from the authorizers is low. I mean, I think that would be irresponsible, right? I mean, this issue, this appeals issue, has been with us a long time. All of us know that. And doggone it, we need to have the courage to do something about it. The idea that 2% of veterans are providing 45% of all appeals, and some of them going 25, 27, 28 years, is simply not right. We're punishing the 98% of veterans who are appealing and doing the right thing. And so we've got to get after this. And we're going to continue to work with Chairman Miller and Chairman Isaacson to make sure we get this legislation.
Mr. Secretary, I understand that, but given where we are in this calendar year, given the challenges that Congress will face this year, and also given the fact that the VSOs are very likely not to be inclined to support preventing veterans from continuing to supplement that record during their appeals, simply because through no fault of their own in many cases, their records are not complete because of having been lost, papers having been lost or disconnected within the VA process.
Well, I don't know about that, but you know, one of the things I learned in the military is we all look out for each other, and this idea that 2% of people can affect a bad outcome for 98% of people just does not make sense in the military culture. So we're going to work with the veteran service organizations. We're going to come up with an optimal solution, and we will bring that to authorizers, and we will expect them to pass it or get it through committee.
That's all I have, Mr. Chair.
Jolly. I'd like to recognize the gentleman, Mr. Jolly, for 5 minutes.
Thank you, Mr. Chairman. Mr. Secretary, or for the panel, when we talked about the VISTA replacement that is likely coming, I know prior to your administration, 2015, there was a little over $600 million allocated for mass. With this now the plan, are you abandoning mass? Because initially it was supposed to be a national rollout, then I understand it was brought back to a pilot program in certain communities, but can you give us an update on mass, the funding for mass, and how it plays with this?
Sure. Congressman, as you know, we have selected the mass project, and we are now in the process of evaluating a pilot site for that. We've selected Boise, Idaho as a potential pilot site. We have actually put the implementation of the pilot site on hold for a brief time in order to make sure that we're making the best decision for veterans and the best decision for taxpayers. We are rolling out the VISTA scheduling enhancement right now. As I mentioned, the 3 sites, the one site that's active in Asheville, North Carolina. We will roll that out further nationally in April. At the same time, evaluate how that's serving our scheduling needs, using the mass option in case the VISTA scheduling is not meeting all of our needs, so that we can go forward with that implementation. So far, I think that we've spent about $9 million, is that correct, on the mass project implementation, and we have other money allocated to support the pilot should we decide to go forward with that later on this year.
So generally speaking, though, mass has greater capabilities, greater function, far more comprehensive than this enhancement.
That's correct.
So can you maybe walk us through the decision to go with VSE and delay or put on hold mass?
Yes. You're correct. The mass project has, or the mass product has much greater capabilities. It's actually a process engineering tool where we would re-engineer the way that we actually deliver clinical care. So it's much more than just a scheduling tool and has other advances that we're looking at right now. Our schedulers, as the Secretary said, using that green screen,
sure,
are in such desperate need of trying to meet the veterans' needs today, improving access, that we feel the responsible thing for veterans right now is to get them tools that are available. And that's why we've rolled out this tool in January. We do not want to hold that up while we are looking at what the right decision is for the system. If it turns out that VISTA scheduling enhancement, once our schedulers get what you see up there, is really meeting the majority of the needs of veterans and of schedulers, probably the right decision for taxpayers is not to spend up to $663 million that you saw that this contract has the cap at, but to be able to continue to roll out VISTA Scheduling Evolution. So this pilot that we're doing right now with VISTA Scheduling Evolution and in April is going to be very, very important for us to understand whether that's meeting the needs of our schedulers and veterans.
What's the additional functionality of mass? In other words, what's the delta that's being left off the table, if you will, by going with VSE?
Yeah, It is primarily a process engineering tool that will help us design our workflow in our clinics. That's the primary advantage. VSE is really only a GUI interface in our VISTA scheduling system. Sure. We also are rolling out something called VAR, which is a mobile application for veterans to actually request and get appointments on their mobile phones. That's also being rolled out as well. Okay. And LaVerne, anything else about MASS, the capability?
Yeah, and I would ask, for a layperson who's not familiar with IT, can you explain kind of in plain language what that delta is? What are we leaving off the table by not pursuing MASS?
What this is the whole process of how you schedule appointments is more than just the computer interface. Right. VISTA Scheduling Evolution is really that computer interface. So a scheduler can see what appointments are available, how do I quickly get a veteran into an empty appointment. That's what you're seeing on what looks more like a Microsoft screen. Right. That's what we're doing right now. What we're evaluating is it worth it to invest hundreds of millions of dollars into something that's much deeper, that actually connects the way that we schedule appointments behind the scenes in a much more sophisticated way? That's why we went through the MASS selection process, and that's the decision which we're going to be making very soon, whether we test this in Boise to start.
Okay. And I didn't mean to cut you off if you had anything to add to that. No.
I think the one thing to remember, and this is the learning around VISTA, is we have 130 different instances. And a key part of really being able to make change fast is that we've got to think through that architecture and get ourselves to a much more simplified state so that MASS or any new capability will be easier versus harder.
Okay, thank you. Mr. Chairman, thank you.
Thank you, Mr. Jolly. At this time, I'd like to recognize the gentleman from North Carolina, Mr. Price.
Thank you, Mr. Chairman. Mr. Secretary, in looking at relatively new and non-incremental items in your budget, I do want to ask you to focus on this caregiver support that you're concentrating on. But I first want to pick up on the exchange you had with Mr. Farr and the reference to the Veterans Courts, and just this, not necessarily a budgetary item, but want to ask you to elaborate a little bit on your experience with this. My experience at home is just remarkably favorable. One of our relatively small counties, Harnett County, has pioneered with the Veterans Court. 2-year anniversary just observed. It's a small scale. 6 graduated last year. 17 veterans currently participating. 14 waiting to be accepted. Somewhat hampered by the difficulty of getting qualified mentors, but that's coming along too. I know this is a source of referrals to you. It's a source of some pretty difficult care cases, no doubt, but I'm sure it's the kind of problem you welcome. And so, have you found formal or informal ways of encouraging this development and scaling it up?
Yes, sir. In fact, when I came into this job as a business guy, I looked at what are the rates of return of all the studies we've done on homelessness. And one of the primary deliverers of the highest rate of return is a Veterans Treatment Court. Eliminating veterans homelessness has the highest rate of return of any investment I've ever seen. Because if you don't eliminate that homelessness situation and provide the veteran the care, they end up in emergency rooms, and all other bad things happen that become much more expensive. So we've been going around the country identifying where do we need veterans treatment courts, where do they not exist. And one of our current pieces of work is in Los Angeles County, which happens to be the place where we have the most homeless veterans. And we have veteran treatment courts in the counties around Los Angeles, but not in Los Angeles County. And so I've been working there. We've eliminated a lawsuit that was existing there. We've put out a new master plan for our 390-acre campus there. But one of the important things we've got to do is get our Veterans Treatment Court in Los Angeles County. And so we're working on that. If we do that, that will help us eliminate veterans homelessness. Very high rate of return.
Thank you. The estimate the judges at home tell me is every dollar invested saving $20.
That may be low, but I
That may
think
be low.
that's a good place to start.
But so much of this up to now has depended on the initiative of local judges, people who understand the value of this, to the extent there can be national leadership in encouraging this and facilitating it.
You're exactly right. We have systematized it, so we actually go across the country and we look for pockets where they don't exist, and we work with the judicial system there. There's also now an association of veteran treatment court judges that get together once a year. I always come and speak to them when we talk about new advances. We also talk about what are the geographies where we don't have them, where we need them.
Good. Well, let me now segue to caregiver support. This is an item you've given some focus to. I know anybody who's looked in on veterans' care in their communities is going to appreciate this as just a pressing and growing need. How are you dealing with it in this budget?
I'm going to ask David to comment in a minute, but from my standpoint, caregivers is one of the most important initiatives that I'm trying to drive. When we send a service member to war, the family goes with them, and we've got to do a better job of caring for these caregivers. At the same time, we have a national crisis in caregivers. As the American population ages, they're going to be seeing the same problems with caregivers that we in the VA already see when people come back from the battlefield. So we've been working very closely with the Elizabeth Dole Foundation, and we've been working very closely to make sure that our programs for caregivers are robust. So, for example, I was recently in California, and I attended a session we were doing with people, older veterans who were suffering some form of dementia. We were doing music therapy with them. While we were doing that therapy, we had all of their caregivers in a different room, and we were helping them solve their problems, and they were helping each other solve their problems. So this becomes very, very important. As you know, the law is that if you're a caregiver post 9/11, you get support. If you're a caregiver pre 9/11, you do not. So this is a great inequality that somehow I suggest the Congress needs to deal with. David?
Yeah, I think, Congressman, as you see, we've requested additional money this year in the current budget request for additional support for caregivers, because exactly as the Secretary said, we have found this is so valuable. This is an important return on investment. If you didn't have caregivers supporting these veterans, they'd be requiring additional inpatient care and additional services. And so we hear how valuable this is, and this is one of the big differentiators of the VA healthcare system from the private sector, where getting caregiver support is very, very difficult.
Thank you. Thank you, Mr. Chairman.
This time I'd like to recognize the gentleman from Ohio, Mr. Joyce, for 5 minutes.
Thank you, Chairman Dent. Secretary McDonald, you were talking about the homelessness situation before, and I've noticed that you asked for $1.6 billion for combating veteran homelessness. In particular, $496 million for the Housing and Urban Development Veterans Affairs Supportive Housing Program, known as HUD-VASH. As a member of that subcommittee as well, can you tell us and the other members of this committee just how your agencies are coordinating to tackle this issue?
Thanks for the cue.
That's a great question. Great question, Congressman Joyce. We have an interagency council that works together against homelessness, and as you know, the President has put priority focus on veterans' homelessness. The work that Secretary Castro, Julian Castro, Secretary Perez, Labor, and I do together is so critically important that we decided to actually travel together to demonstrate to the local communities how important it was to work interagency to get this done. Obviously, labor is about getting the veterans employed. Secretary Castro is about getting them housed. And then importantly, we provide the care. It's not really just about the housing, it's also about the care. So we travel together. The HUD-VASH program is frankly a miracle, because it allows us to give a voucher to a veteran. It allows them to go under roof. It follows a strategy called Housing First. Housing First doesn't mean housing only, but it means if you get that low level of Maslow's hierarchy of needs solved, you can then provide the care, and the individual will work with you on the care because the housing's already taken care of. One of the things we've had to do is work in different communities. Number one, to increase the HUD-VASH voucher amount. We've increased the amount twice in Los Angeles.
Number two, work with landlords to rent, and we've done mayor's challenges, and I've done challenges to get the mayors to rent to HUD-VASH voucher holders. Number three is to get developers to build new housing, because in some communities there just isn't the housing stock, and we can bundle the vouchers to do that. So it's a really, really positive program.
That's great to hear.
Last year we took care of 365,000 veterans and their family members.
It's great to hear, and it's great to hear that you're coordinating the funds to make sure that we're delivering the services that are necessary. Ms. Council, I appreciate the fact that you've taken over a rather large task. I know when I was going to visit VA hospitals, one thing they talked about was the inability to coordinate platforms. So that certainly has to be an issue for you. And the fact that you're taking this, and I noticed that you have asked for $370.1 million, which is a 105% increase over the 16 enacted level. In order to, can you please tell us what you're doing with this increase in funding to help protect the veterans' very sensitive information?
I think you're referring to our new security budget and
Yes.
fully supporting security. One of the key initiatives when I first came into this role in July was to secure and think about our security much more holistically across the enterprise. So within the first 90 days, we created our enterprise security strategy. It includes 8 core domains within the organization and frankly changes our posture as to how we secure information, who is using it. We included privacy into it, as well as governance, education, and also how we hire. So the use of those dollars are really to fully fund our elimination of our material weakness by going after some of our FSMA and FSCAM issues and repeat issues that we've had. Our objective is by the end of 2017, we would have eliminated all of those material issues. And so that is really our focus. We are going into each of those sites. We're working with our auditors to get out in front of when they're coming in, but also to make sure that we're truly remediating these issues and eliminating them for good.
And preparing for any type of cyber attack as well?
We're always preparing for any kind of cyber attack, and the real issue with security is that you're always on defense, but you also have a great deal of offense that you can do, and we're ensuring that we're also doing that through education.
And one last question, if you will. Who do you believe those records, who do you believe those are? The VAs?
Those are the veterans' records, and we have the due responsibility as the stewards to protect them.
Thank you very much. Back to you, Mr. Chairman.
Thank you. With 4 seconds remaining. Okay, this time I'd like to recognize the gentleman from California, Mr. Farr, for 5 minutes.
Thank you very much, Mr. Chairman. I want to congratulate you on your distinguished career, West Point graduate, private sector CEO, and now secretary. You know, I've sat on this committee almost 20 years, and this is the only committee in either house of the Congress that has both DOD and VA responsibility. I've always thought that if this was the perfect world, VA could work themselves out of a job, because people would get out of the military as they get out of it, all kinds of things, and then they just go back into the civilian world, and we take care of them. We've created this silo that's now $178 billion silo that it's very good what we're doing, but it's also very expensive, and I think that that's why Mr. Fortenberry and I are sort of Siamese twins on this collaborative idea that we ought to try to go back, and I know you really understand that and want to bring in more market mechanisms to make services, stimulate services to be better. I've got a problem because we have sort of the perfect solution. When Fort Ord closed, largest training base in the United States to ever close, a lot of that housing we acquired through local veterans organizations as transitional housing. Our community college built a campus there. We have the new VA DOD clinic going in. We have a new cemetery going in, veteran cemetery. We have, and this housing is for homeless veterans, and they've housed families. They've had to raise the money to rehab these housing because the Army never built it for California code standards. it's expensive. But once you get those families into that housing, they're there for 3 years, and they can walk to every service they need. The thing they all need is this, you know, treatment. They got serious problems. That's why they're homeless. Our HUD vouchers, which are wonderful, but guess what? The rents in this area are so high that nobody will take them. And yet we have, and what we need to do is rehab some more of these houses. We got the facilities. Can you help us do that and not just use all the money to get them in, to get vets into housing? Because in some places that's not going to work. And transitional housing that you can stay in for 3 years is a long time. And so this is probably the safest, best kind of, we call it the Veterans Village, where you can be located. And that we don't have anything to stimulate more creation of more of those, or to help those that have actually created them. So the question is, can you make sure that where there are resources for homeless veterans, that we support those?
Yeah, I couldn't agree with you more. When I was in Los Angeles, we did a thing called the Blue Butterfly Project, where we used some old Navy housing, and we put female veterans in, and their children. But we had to, one of the things we're working on in VA is to become a more principle-based organization rather than a rule-based organization. I know that sounds unusual to members of Congress who create rules, but sometimes the rules get in the way of taking care of the veteran. And in this particular case, there was a law that said, well, you can't have housing for female veterans only. You know, but what female veteran and her family, single female veteran, wants to live in a neighborhood of male veterans? But, you know, we found a way around it because we worked on the principle of taking care of those veterans. So again, the HUD-VASH voucher amount, in Los Angeles, we've raised it twice. I think we need to take a look at the HUD-VASH voucher amount in your district and see if it's meeting the needs of veterans, and if not,
it's the same as LA. All of California coastal cities are just the most
absolutely.
Expensive places to rent in the United States. But this is different. We've got the housing.
I understand.
We just need to fix it up, and what comes with this housing is treatment, which
Yes.
is a little bit more difficult with the.
In the Blue Butterfly Project, we used private sector partners, Home Depot Foundation, others that helped us fix up the housing. So we know how to do this, so we'll get together on it and make sure we take advantage of that housing.
One last comment, if I can. My time's just about out. I would hope you have 10 months left. You bring a unique vision to this, and with your military background, I think that we're dealing with so many problems that DOD ought to be handling. Sort of they dump their problems on VA. You can't get into VA unless you've been through DOD. So if sort of the cause of problems are while you're in the DOD community, why can't we hold DOD more responsible? These are essentially the costs of war. And I think you have the unique ability to suggest some of these things that ought to be carried by DOD in their budget and not fall on your responsibility.
We have a very good relationship with Secretary Carter, and we've had many very open, honest discussions. To me, it really goes back to we as a society have to understand the cost of war after the veteran comes home before we send them into the war. Because that's where the greater costs exist, at least in human terms.
Could the DOD do some ounce of prevention?
Well, I think that's part of it, but I also think it's all of us who may call for the use of military force need to make sure we understand what it's like when you come out. You know, we have, David was referring to this earlier, for the first time in our history, I think we have 5 veterans who are quadriplegics, who have no arms and no legs. Yet, if you met these individuals, I think now Sergeant Travis Mills from the 82nd Airborne Division, he could walk right in front of you and you would have no idea. But people are 10 times more likely to survive the battlefield, but they're going to survive with more grievous injuries. And we have to recognize that, and we have to prepare for it before we send people into harm's way, rather than wait till they come out and then wonder why the budget's going up.
Thank you, Mr. Farr. I have one last question, I think, and the ranking member has one last question, then we'll conclude the hearing. But I also have a few questions that I'll submit for the record that you can respond to then at your convenience. Secretary, we know that you are sending the Hill your legislative proposal to consolidate all the non-VA care programs into one program as you were directed by statute. How will the new program, if enacted, be managed within the VA, and how long will it realistically take to get it up and running? And how do you propose to strengthen the business and claims payment processes in the new consolidated program, which have been weak to date and caused low participation?
That's a great question. We have set up a whole new office to manage this with a whole new leader. David, why don't you go through the details of that, if you don't mind?
Within VHA, I've established a new Deputy Undersecretary for Community Care and an organization that's really developing the infrastructure to manage this. We are very anxious to move on with this. That's why we're looking for the support in the legislative authorities to move forward with the plan that we submitted in October of 2015. We believe that we will be able to go out with a RFP in the fall to be able to start making decisions on what we're going to do in-house and what we can get from the private sector. We do believe that outsourcing for some of these functions is a realistic option if we can get the right bids back in. And so we have very aggressive plans to be able to implement this. We're going to be doing this on the fly as the train's moving because we're taking care of veterans in the community every day.
Thank you, Dr. Shulkin. I have nothing else. Representative Bishop.
Thank you very much. One last question. I recently met with an individual from the VA hospital located in Dublin, Georgia, and he raised a concern that there's currently a 10-to-1 patient-nurse ratio in the VA healthcare system as compared to a 7-to-1 ratio in the private sector. And while I understand that the VA ratio is high in comparison to the private sector, I also recognize that the VA operates under very different fiscal constraints. Are there any efforts underway right now to bring in more registered nurses in order to bring down that ratio within the VA health agency?
Okay, I'd be glad to answer that. As you know, I've spent my entire career running hospitals in the private sector. The ratios are not fixed, except for in states that legislate that, like California. In general, a ratio of between 7 to 10 is what you will find in many hospitals across the country. It depends on the severity of the patient. Most hospitals have a severity-adjusted nursing staffing ratio. The VA healthcare system is absolutely within the standards of private sector, certainly not worse than that. Do we have a nursing shortage in some areas, like in Dublin, Georgia, where it's hard to recruit nurses? Absolutely. We have open solicitations for nurses to join the VA. We are eager to have all qualified candidates, but I do not want to give the impression that the nursing care in VA is anything less than you would find in the private sector. In fact, just recently in the Journal of the American Medical Association a month ago, independent studies found that VA outcomes, mortality rates, are actually better than the private sector in conditions like acute myocardial infarction and congestive heart failure.
Yeah, I guess in connection with the VA Center at Dublin, this particular individual was concerned that being able to keep up with veterans, especially those that have brain injury, PTSD, or other mental health concerns, require a lot more close supervision, and with that high ratio, it works a real hardship on the staff, and sometimes it places them at great risk, both the patient and the staff. And he raised that question with a genuine, authentic concern, and I told him that I would bring that to your attention and find out what if anything could be done about that, and if anything was being planned for that. And obviously there's some fiscal restraints.
Yeah, I've been to the Dublin facility. I spoke to the director, Mary Alice, earlier this week. We are very focused on nursing. Every hospital knows that it's only as good as its nurses. It is the single most important professional to have the right staff and the right numbers. And you're absolutely right. The spinal cord injury patients and TBI patients require intensity of services of nursing that really are almost incomparable to other services. So we are focused on that. Dublin, as you know, is a challenge because of its location, but we're doing everything we can to get the right professionals there.
Thank you.
Thank you, Mr. Bishop. And I just want to inform the members that our next hearing, of course, is going to be tomorrow morning at 9:30 a.m. For the Secretaries of Military Installations in room 210 on the house side of the Capitol Visitor Center. Don't get lost, okay? So this hearing is adjourned. We will get lost in that one.